Panelist speech 2 will be delivered by Dr. Reiko Hayashi, Director, Department of International Research and Cooperation, IPSS. The title of her presentation is Evolution of Health in the Context of Longevity Extension, the Case of Japan. The floor is yours, Dr. Hayashi. Good afternoon, ladies and gentlemen. My name is Hayashi. I serve as the Director of the Department of Research and Cooperation at IPSS. The title of my presentation is Evolution of Health in the Context of Longevity Extension, and I would like to take up the case of Japan. Hopefully, I would be able to take up a long horizon and talk about the changes that have occurred in the health situation of Japan. We're looking at health, but death is a very objective data in looking at life. And to a certain extent, health issues can be understood by looking at death statistics and the fluctuation of death. So in the first couple of pages, I would like to speak about the fluctuation of deaths. This plots life expectancy and number of deaths. And the green line represents the life expectancy, and the data plots the life expectancy from the late 19th century, and until around the 1920s, the first half, life expectancy had continued to grow. There are signs that life expectancy had expanded, although that might be due to some data. And from 1920, a further rise in life expectancy because infant mortality rate had begun to go down since the 1920s, and thus this trend began to be seen. And then there's a stage without data during the World Wars, and then you would see that thereafter, after the war, there has been increase of life expectancy because TB, which was one of the major death causes, had begun to be treated effectively, and therefore that had pushed up life expectancy. And then in the 60s, TB was no longer the biggest cause, and from communicable diseases, non-communicable diseases became major causes of death. And although the increase of life expectancy began to slow down, it continued to go up. And this follows the pattern just described by Dr. Mellet in the case of France. On the other hand, life expectancy is calculated without now in the blue line we took up the number of deaths, and when there is young people it goes down, and when there are more older people it goes up. And it's also an indicator that you can truly feel, like for example, you can also look at the indicator in order to guess the business cycle of funeral companies. Pre-war period, you see the rise this time around, but that might be partly due to many people beginning to register. But the number of deaths was around 1 million per year, and during the World War, it went up, and then it came down to around 600,000. 60s, 70s, the number of deaths had dropped. But then, more recently, from 1980, we began to see another increase of deaths. And at the moment, it's in the order of 1.2 or 1.3 million per year. And therefore, the level of deaths has now gone back to pre-war levels. So, whilst life expectancy goes up, so is the number of deaths. It also continues to go up, and that is the pattern of Japan. In 1898, the first census demographic statistics was taken, and based upon the international standard, we've been able to plot the cause-specific death rate. And by using those statistics, we have plotted the cause-specific death rate since the mid or late 19th century. Pre-war period, TB or pneumonia had been the major causes of death, and Spanish flu was the biggest impact here, and communicable disease became important cause. But after the war, non-communicable disease became a major cause. And red is cerebrovascular diseases and the number of deaths. 1961, the universal health insurance system was introduced. And as long as you were registered as a Japanese citizen, you were covered by the universal health insurance. And here you see cerebrovascular diseases. And on nationwide basis, health promotion campaign was introduced, and hypertension people were identified and urged to go to the hospital. And also through universal health insurance, all people began to have access to hypertension medication, and that is why the number of deaths caused by cerebrovascular diseases suddenly drops after that campaign or program had been introduced. This is the 1994-1995 heart-related deaths had gone up and gone down. With INED, we are doing a joint project on this, but the change of criteria for the cause of death was changed, and because MHLW suddenly put up a notice not to write down the heart disease as a specific death cause, that is one of the reasons why this line suddenly goes up. And right now, the biggest cause is cancer. So, in Japan, there had been various changes caused in terms of the number of patients by disease, while life expectancy was extended. And another big change had occurred in the location of deaths in Japan. Since 1950, this diagram plots the place of death, and 85% of people died at home back then. The majority of people died at home. And then, with the progress of healthcare services and spread, we began to see a higher number of people dying in hospitals, and the lines cross at around 1975. And in this process, we see an increase in the number of people who die in hospitals rather than at home. As mentioned by Dr. Endo, community-based comprehensive care is being promoted. The government is recommending that people who can die at home should stay at home to the extent possible. And therefore, the proportion of people who die at home slightly increased, while the people who die in hospitals slightly declined because of that government campaign. So this line, hospital death line, has not continued to just linearly go up. But however, the number of people who die at facilities is also going up. So this indicates the facilitization or medicalization of death. So with the death pattern changing and expectancy of life increasing, the key is not to prolong the unhealthy years. You're alive but not healthy. And in the Health Japan 21 campaign, we're trying to increase the healthy life expectancy, become longer than life expectancy, and each municipality is trying to calculate the indicator in order to maximize healthy life expectancy And this has attracted attention. As mentioned by Dr. Endo, healthy life expectancy is the expression used, but there are many ways to interpret health. So a uniform definition has to be applied to measure that, and MHLW has been conducting these statistics since 1989, and because of health reasons, have there been caused any problems in the ADL? So that's the criteria that has been introduced in Japan to draw the demarcation between healthy and unhealthy. And for men and women, similarly, with life expectancy going up since 2001 to 2013, the healthy life expectancy also had gone up. So the official definition is having problems in activity of daily life, but people can interpret that criteria differently. Do you have a problem in your daily life? If you say yes, that may be caused by disability or impairment, but also diseases can cause problems in daily life. Or if you became ill, did you go to the clinic or hospital? That could be one criteria. Or do you think you are healthy or not? That kind of subjective health can also serve as a criteria. In Japan, we've been quite diligent in taking data, so there's much data at the Ministry of Health, Welfare and Labor, and we can get a nationwide statistics as a big sample. And even when we look at just the MHLW data, there are so many different indicators as shown. For example, patient survey is conducted at hospitals for inpatients and outpatients, which would give us the data on the number of patients in 1986 before the MHLW survey on the basic life of the people was introduced. Other types of survey had been conducted, and similar questions had been asked. For example, the number of people who are ill and the name of disease, the treatment, the number of days in bed. Do you have any impairment, physical impairment? Is there activity limitation? How many days were you in bed? Are you bedridden? Do you need care? What about the ADL, activities of daily living? And how about subjective health? Those questions are asked. Since 1986, the basic survey on the life of the Japanese was introduced in 1986. So the design of the questions changed in 1986. And every 3 years, this major survey is conducted. After 1998, in the year 2000, long-term care insurance was introduced. So the first survey after the long-term care insurance was introduced was conducted in 2001, and new questions were introduced. Do you need help? Are you independent? What is the degree of care you require under the long-term care insurance? Those questions were newly introduced. So, what are the characteristics of each of these health indicators, and how have the statistics changed? Age and gender have a major impact on health, but here we do not divide by gender, only by age. And I said that one indicator is to judge health or lack of health due to illness. And according to the nationwide survey, when asked whether you are ill or not, we obtained certain responses, and this was taken from those responses. In the case of 1980, the higher age you are, people who respond that they have diseases increases. But before that, the final age bracket had not seen any significant increase in the respondents who say they are ill. It's because in the past, people thought it was ordinary that you are ill because when you get aged, and even when you think you are ill, if you are aged, you didn't go to the hospital. But then thereafter, healthcare expenses was offered free of charge. Healthcare treatment to late elderlies beyond 70 became free of charge. But that led to the healthcare expense increasing, and that would require us to conduct a drastic reform of the healthcare system, which is known all to you, but that is a different subject for a different event. And also having activity limitation due to health reasons. And from 1980s, where data became available, it has gone up by age bracket. And last year, the final age bracket, which is 85 and higher, more than half of those who are 85 and higher responded that they do feel the impact of health to their daily lives. The numbers differ between 1998 because even if one uses the same question, this one does not include those who were in bed for 1 month or longer, but this one does not. And that is one of the reasons for this gap. And when we calculate healthy life expectancy based upon this data, we need to be careful. Next, subjectively unhealthy. We give a 5-point scale, not so good, not good at all. Those were the choices that respondents chose, and this plots by age bracket. And the trend is the same. 40% of them are 45% of those who are 85 and above feel that they are subjectively unhealthy. Do you need care or do you need help? The responses differ depending on the way that the question is asked, but help becomes more frequently necessary as one ages, but it's not the case that there is a significant increase linked to age. And then bedridden. This is the graph for the bedridden elderlies. So we have tried to multiply the statistics and add it up to give the aggregate based upon the previous data. On the left, for men and women, red is the life expectancy, and blue is non-bedridden life expectancy. Orange, life expectancy for those who don't need help. Purple is those who subjectively think that they are healthy and the life expectancy of those people. And finally, non-ADL problem life expectancy in green. So non-bedridden or no impact to daily life and subjective health. After the year 2000, there's increase in life expectancy. No need of help. There's not any significant increase amongst women, but if we look at the other indicators, in proportion to the prolongation of life expectancy, these cohorts also see the increase in life expectancy as well. And then 2016 data. Already, the comprehensive survey of living conditions has obtained 2016 data. We haven't conducted a full analysis, but there has been a significant increase. So the 21 campaign, Healthy Life Expectation 21 program seems to be delivering effect. But when we look at the relationship of health indicators of needing care, daily activity limited, and subjectively unhealthy, There are those who say they need care, but they're not limited in terms of daily activity or they're subjectively healthy. But generally speaking, those who are 65 and above, many of them are feeling that they are subjectively healthy, and on year basis, those who responded that they are healthy has increased. So who are the people who are feeling in what way and what are their life expectancies? We have to do some more analysis. Finally, the number of people in facilities. The MHLW survey does not subject those people in the facility within the survey. So there are those who say that maybe life expectancy in average is not growing so much because the ministry does not take into consideration the people in facility. So here we have done a survey on those in the facility and assumes that all of them need help and have difficulty in their daily lives. And we did a calculation by gender. This is non-bedridden, necessary help necessary, and this is the healthy life expectancy. The pink under red and the green. Light green under green is the healthy life expectancy. So, even if we calculate that all of those in the facility are bedridden, this indicates that the healthy life expectancy has continued to grow. So, my conclusion is that life expectancy prolongation in Japan is accompanied by the expansion in healthy life expectancy, and this point should be taken into consideration to come up with an estimate of what needs to be done in terms of long-term care insurance system. There has been a bonus of prolonged life expectancies because that has been accompanied by healthy life also becoming longer. Thank you very much.
Ms. Hayashi, thank you very much.